Hello, good evening, everyone. Welcome to the second day of CRS conference. We had a great attendance yesterday and a very engaging audience. So we hope the second day also continues to be engaging. I would request Dr. Chandrika Bhatt to introduce our chairpersons for the first session of the day, and also all of those who are participating from India and from abroad would request to continue your interaction and send all your questions during the talk so that the chairpersons could take those questions at the end of the talk. Over to you, Dr. Chandrika.
Good evening, everyone. It's my pleasure to introduce our chairpersons for the first session. Dr. Dhiren Gupta is the Deputy Director, Division of Pediatric Emergency Critical Care Pulmonology and Allergy Disorders at Sir Gangaram Hospital, New Delhi. He has been the chairperson of the Pediatric Critical Care IAP chapter, the Chancellor of Pediatric Critical Care College in 2021. He has also received the Vishishta Chikitsa Ratna Award for his contribution in the field of pediatric intensive care by the Union Health Minister. He's the guest executive editor of Indian Pediatrics, IJCCM, IJOP, and IJPCCM. He has numerous publications to his credit and is a distinguished speaker at international and national conferences. So welcome, Dr. Dhiren. Our next chairperson, Dr. Sonu Udani. She's the Medical Director and Head Critical Care and Emergency Services at SRCC Children's Hospital in Mumbai. She's the founder member of ISCCM and College of Pediatric Critical Care. She's a fellow of ICCCM. She has been the past chairman of our intensive care chapter and also the past chairperson of Mumbai chapter of intensive care. She's the Chancellor of College of Pediatric Critical Care from 2013 to 2015. She has 30 years of experience in the field of pediatrics and critical care in children and has been an editor and contributor to numerous books in pediatrics and critical care. So welcome, ma'am. Dr. Lokesh Lingappa is our third chairperson. He's a clinical lead division of pediatric neurosciences at Rainbow Children's Hospital in Hyderabad. He has received the Anicia Vasant Memorial Award by NIMHANS and had the best paper in the neuro-oncology conference at Brazil. His areas of interest include stroke and acute care neurology. I welcome all our chairpersons and I request Dr. Lokesh to kindly introduce Dr. Terence and kickstart the session. Thank you.
Thank you, Dr. Chandrika, for that introduction. I introduced Dr. Terence, who's working as a pediatric neurologist at Children's Hospital in Singapore, and he has a keen interest in neuroimmunology and has been working on this and published on the effect of the acute necrotizing encephalitis, how the neuroimmunology works. And acute necrotizing encephalitis, I think many of you are aware, is one of the most devastating illness what we find in children, and some of these children die within less than 12 hours. And those who survive have had very severe long-term neurological disabilities. So anything to improve the quality of outcome in these children would be very welcome. I ask Dr. Terence to start his talk. Thank you.
Okay, thanks, Lokesh. Can everyone hear me well?
Yes, we can.
Yeah, okay. So thanks, Chandrika and Rakshay for the invitation to speak today. But I understand that most of the audience are not neurologists, right? You're pediatricians in different fields. So I'll try to explain myself along the way, right? So my topic today is the cytokine storm of acute necrotizing encephalopathy, or in short, ANE. Right. So ANE is one of a number of syndromes of what we call the infection-triggered encephalopathies. Right. So meaning an infection that triggers a cascade of events that happen in the brain, right, and causing a rapid deterioration and often resulting in poor outcomes in children. But some of the syndromes are mild, like a child with a febrile seizure with a prolonged encephalopathy. And also the second condition here with the acronym MERS, which essentially stands for mild encephalopathy with a splenial lesion in the corpus callosum, and what I've put out in the circle. Whereas the most severe conditions are ANE, AESD, HSES, and AFCE. So I will speak a lot more about ANE later, but just briefly, the other syndromes. AESD is an acute encephalopathy with a biphasic clinical cause of seizures. And a very characteristic pattern is what you see on the MRI, restricted diffusion in what we call like a bright tree, like branches of a tree. right? Like a bright tree pattern, right? And then the two most severe conditions, HSCS and AFC, children who present very quickly, deteriorate and die within like 24 to 48 hours. In HSES, often there's shock, hypotension, and on the MRI, we usually visualize some infarcts in areas that are watershed areas, so that we have watershed infarcts in the MRI. In AFC, all we see is just global cerebral edema, and this can happen very acutely. So we can have a patient that has a first CT scan that is normal, and within 12 hours, when you repeat a different scan, an MRI or another CT, we have global cerebral edema and coning. So these two are the most severe syndromes. But most children actually present in the hospital with a very minor illness, like an upper respiratory tract infection or gastroenteritis, with a number of common viruses, commonly the influenza viruses or human herpes virus 6 or 7, or adenovirus or metapneumovirus. And then within the second to fourth day of the illness is when the neurological symptoms will surface. So this is another pictorial looking at the syndromes in terms of outcome, right? So the conditions AESD and A&E often lead to moderate to severe disability, but AFCE and HSES often result in death, right? In a number of the most severe syndromes, you also have multi-organ involvement or extraneuronal involvement. Okay, so I'm going to talk a lot more about A&E now, because this is the focus of the talk today, right? So essentially, these are clinical radiological syndromes, right? So you must have an infection, a virus, a pathogen external to the CNS, and then producing a febrile encephalopathy, and have a characteristic pattern that we see on imaging, right? So in A&E, what we encounter is that often the clinical syndrome is coma, seizures with motor signs, either pyramidal or extrapyramidal signs. And then neuroimaging is quite remarkable. So there's usually bilateral thalamus involvement and the pons, and also often the cerebellum and the cerebral white matter, and usually with a hemorrhagic component. On the MRI, I'll come to that later. So when we do a CSF analysis, there is usually an absence of pleocytosis. So there's no increase in cell count, but very high protein levels. And in severe cases in A&E, there is often hypotension, thrombocytopenia, liver failure, and coagulopathy. So this is the peculiar thing about the MRI and the thalamus in A&E. We see a interesting pattern where there's a trilaminar or three-layer pattern to the thalamic lesions. So a central area of hemorrhage, right, followed by an area of restricted diffusion, which implies a cytotoxic edema. And then what we call radiologically as facilitated diffusion or on the outermost layer, and this represents vasogenic edema. So this is unique to A&E in itself. So we do have other brain syndromes, acute encephalopathy syndromes with thalamic lesions, but we do not usually see this particular trilaminar pattern of injury. So A&E and many of the ITES or the infection-triggered encephalopathy syndromes are complex, right? So we do know that there is some immune response, and but this immune response is not an adaptive immune response because we do not see cells. There's absence of pleocytosis in the CSF, but we do see a lot of proteins. And I have slides later to show you that we have evidence that there is actually a hypercytokinemia in the CNS. So one postulation is that this could be because of a cytokine storm externally, meaning the infection external to the CNS producing a huge production of cytokines that spill over into the brain. But the other theory is that maybe the cytokines do not arise from outside the CNS, but inside the CNS via microglial activation. There's also lines of evidence to suggest that there's some amount of mitochondrial dysfunction and energy failure. There's some issue that we recognize that the rapid rise in temperature also leads to a breakdown in cell metabolism. And then there's the component of excitotoxicity or seizures and status epilepticus, producing further excitation in the brain and further injury, resulting in cerebral edema. So it's a complex pathobiology all happening at the same time. And hypercytokinemia is just one of the features of this condition. We have found in a small number of children, there are certain genes that may at least create a vulnerability or a susceptibility to A&E, right? So these are genes that affect metabolism, like RANBP2 or carnitine palmitoyl transferase. There's some genes that with the interleukin-1 that modulate the immune response. And in excitotoxicity, there's some genes that regulate NMDA receptors and excitation. So this is some work from the Japanese looking at the whole range of infection-triggered encephalopathy seizures and the levels of interleukin-6 in the serum and CSF. So in the most severe syndromes, there is a huge production of interleukin-6. A normal level in the child is usually in just double digits, but in these severe syndromes, it runs into the thousands or 10,000s. In the less severe syndromes, in just a nondescript acute febrile encephalopathy, you will see levels up to 100, and similarly in children with febrile seizures. In HSES and A&E, we tend to see a bigger response in the serum than the CSF, which led to the idea that maybe this could be a spillover into the brain. But in children with AESD, often there's a higher response in the brain itself. And so thereby there's credence to the idea that maybe this is endogenous. So in the children with acute necrotizing encephalopathy, there's a severity score developed by the Japanese that looks at certain clinical features like the age, like an older child, a child with a high protein in the CSF, the presence of a brainstem lesion, and also other extra neuronal features like low platelets and shock and emission. And this is validated against outcomes. So children who have a score of 5 to 9 have a very high risk of death or severe disability. Right? And children who score very low, like 0 to 1, have a good chance of a normal or a mild disability outcome. So what is also known is that children who have a higher level of interleukin-6 in the serum are the ones who are most likely to have a poor outcome. So knowing this, we attempted trying to modify the interleukin-6 response in some patients with A&E. So this is prior to COVID. We published a series of 3 children with A&E in whom we had used intravenous tocilizumab, which is an interleukin-6 receptor inhibitor. Right. So this is, I'm presenting to you the worst patient in the series, the patient with the most severe illness. This is a 9-year-old girl with a febrile upper respiratory tract infection and gastroenteritis. Then on the second day, developed status epilepticus and a rapid descent into coma, dystonia, and hemiplegia. And she had influenza B virus in nasal swab. Her score was quite high. Her risk score was 6 because she was an older girl with high protein in the CSF, brainstem lesions, and low platelets. So on the first day of admission, which is in the second day of disease, we gave her both together IV methylprednisolone and tocilizumab. So after a long, this is an MRI that we obtained for her. So showing the classic lesions in the thalamus, cerebellum, and in the cerebral cortex itself. And for her, she had hemorrhage in many areas, not just the thalamus, but also in the cortex and in the cerebellum. So after a long hospital stay and recovery and rehab, this is her 6 months post-illness. So without any motor signs, with the only deficit she has is a visual field defect, which I think is a result of the hemorrhage in the right parieto-occipital lobe, and also very mild learning difficulties. So a fairly good outcome for someone who would have had a very severe outcome prior to the use of tocilizumab. So the usual outcomes are usually quadriplegia and a patient is dependent for care. So, so since then we've used tocilizumab in a larger number of patients with A&E. So this is some historical data of use of IV steroids and IVIG, which was the usual treatments you would do for children with A&E in the past. And then after the time we started using tocilizumab, and also hypothermia is what we add on now for patients with severe disease. Right? So in the past, children who had A&E with maybe milder or moderate encephalopathy, like 13 GCS or Glasgow Coma Scale of 13 to 14 or 9 to 12, usually would do well with the steroids and IVIG. Right? But this is the modified Rankin score. In the colors blue and yellow are normal or near normal with, I think it was 2 patients with a moderate disability. But all those patients in the past with severe disease, GCS less than 8, all had either a mortality outcome or outcome with severe or moderate disability. But after the time when we started to intervene with anti-cytokine strategies, we have at least a fair number of children who actually have a normal or a mild disability outcome, despite the very severe presentation in the beginning. So when you looked at the most severe cases, right, the ones who had severe disability and death, what you recognize is that those were children who either received tocilizumab late after 48 hours of presentation, or those who had an overlap with hemorrhagic shock encephalopathy syndrome where there was significant hypotension. So what we postulate is the hypotension and hypoperfusion contributes to additional brain injury, which contributes to death and the disability. So after we've published in this, there's other colleagues overseas who have used tocilizumab in A&E as well. And this is some data from our colleagues in Malaysia and also in the US. Right? So altogether, there's a total of 25 patients who have received tocilizumab in A&E. Right? There's a little bit of severity bias here because in the early treatment group, there were 6 children who died within 48 hours. And this is probably represents the most severe spectrum with HSES as well. Whereas in the late treatment group, there were no deaths. Right? But what is striking is that those survivors who received an early treatment with tocilizumab had a higher proportion of them with a good outcome. And this is a mild or normal, a mild disability or a normal outcome, MRS 0 to 2. Right? Although this does not yet achieve significance. Right? But the numbers are small, and there's only 25 treated patients. Okay, so in the COVID years, we've also identified that you can have acute necrotizing encephalopathy in relation to the COVID virus, the SARS-CoV-2 virus. And so this is a patient that we had as well. So a 7-year-old boy who developed a COVID upper respiratory tract infection without pneumonia. And because he had had a previous COVID infection, he was unvaccinated to COVID. So this was his second COVID infection, and developed an encephalopathy and seizures on day 2 of illness, and very severe the external or extra neurological involvement, severe liver transaminitis, acute kidney injury, low platelets, lymphopenia, high ferritin, and D dimers. He did not meet criteria for MISC, or the multi-system inflammatory syndrome in COVID, because there was only one sort of organ system involved, despite having more than 4 markers of inflammation elevated. His CSF protein was high, but without pleocytosis, and the COVID virus was absent in the CNS. So he received methylprednisolone. He was also given immunoglobulins because on the first day, we had not completely ruled out MISC, right? And then we administered cooling to a temperature of 35 to 36, as well as tocilizumab. And he made a fairly good outcome. This after 1 month in hospital. A little bit ataxic.
What is the name?
And still having a little bit of language issues, but without any motor syndrome or motor deficits. Yeah, and he's gone on to make a better outcome and has returned back to school. So for him, I think what was more remarkable is not so much that he responded to tocilizumab, is that he had imaging features that were a little bit different from the standard or sporadic acute necrotizing encephalopathy. So he had lesions in the bilateral insular area, in the external capsule, globus pallidus, caudate nucleus, and then also the medial temporal lesions with the amygdala, in the midbrain, periaqueductal gray areas as well as the cerebellar and cerebral gray matter, right? So these are additional features to what we would see in standard acute necrotizing encephalopathy. We are aware of a genetic form of ANE, which we call ANE1, which shares some of these features. But in any cohort of ANE, you would only have just a small number of patients that may have features of ANE1. The majority would have features of a standard ANE. Right? So this is what we would see in people who have, these are adults and children who have the RANBP2 mutation and ANE1, right? So similar lesions affecting the amygdala, the external capsule, the other brainstem structures. And in ANE1, there's also a cervical spinal cord lesion. When we looked at all of the COVID-19 related ANE reported in the literature, we find that the majority of them share the same features, right? So rather than seeing just a small number having this extra thalamic lesions, the majority of them have lesions that are similar to ANE1. And in the few patients that have been tested for ANE1, they were tested for the RANBP2 mutation, they were negative, including our patient. So the RANBP2 protein is a protein that it's found in a nuclear pore 358, which is on the cytosolic end of the nuclear pore, and it functions via this modifying protein E3, modifying enzyme to a process called summoylation to modify things that pass through the nucleus in and out, right? So this is at the nuclear membrane into the cytoplasmic area and into the nucleus. So it guards the nuclear pore and allows passage of either proteins or mRNA in and out of the nuclear pore. We now know a little bit more about the nuclear pore 358. It has some actions in terms of immune activation, in terms of microglial activation and chemokine signaling. It has some functions related to the mitochondria, and loss of the RANBP2 can induce a mitochondrial dysfunction. It has a lot of roles in mRNA handling and also nucleocytoplasmic transport. So, so what we think is, or at least should be, the understanding of ANE now is that we do have, yes, the standard sporadic ANE, and we are aware of a small number of patients that have a genetic ANE or RANBP2 encephalopathy, where they have extra thalamic lesions in the brain, but they usually do not have any extra neuronal manifestation. So there's no organ system involvement. But we do now see that we think that maybe in COVID A&E, it's a different form or a kind of A&E where we do see the same extra thalamic lesions, but also a marked organ system involvement, which is different from influenza or the traditional understanding of A&E, where thrombocytopenia and hypertension and liver failure are the key things. But in COVID A&E, we see more lymphopenia, elevated ferritin, D-dimers, and liver and renal failure. So I'm just going to end with just some slides about what we do for patients with A&E. So essentially, this is our management plan for those children with severe A&E, right? So not those with a GCS of 9 to 12, where they may not need more than just methylprednisolone or IVIG. But these are for the children with severe disease, like GCS less than 8, often ventilated and nursed in the ICU. Right? So we are very aggressive with seizure management because this is part of the problem if there's excitotoxicity and untreated seizure. We try to cool the children down to at least 35 to 36 and maintain this for 72 hours. If there's any indication of an external infection, we will try to treat that. And we would administer methylprednisolone and tocilizumab very quickly as soon as we can, as soon as we've established the diagnosis on MRI or the CT scan, and try to give this within the first 24 to 48 hours. Then maintain the rest of the organs, and any neuro rehab related treatments will need to be instituted as well. So the key points, at least I'm trying to bring over, is that there is a time is brain situation that exists in treating children with acute necrotizing encephalopathy, particularly the children with severe disease. And anti-cytokine strategies, either with tocilizumab and hypotonia, which also does help to moderate and bring down cytokines, may help improve outcomes, but only if given early in the disease. Right. So that's all I have for you. Thank you.
Yeah, thank you, Dr. Terence, for that lucid talk on the pathophysiology and how the intervention works in this devastating condition. Actually, we have seen a lot of children where the interleukin-6 is not elevated as such, but still they have quite a severe disease. But we have gone ahead and given the tocilizumab after the paper you people had published. The outcomes are still variable, but definitely the outcomes are much better than what you have shown. Without tocilizumab and with tocilizumab, there is a definite difference in the outcomes. And it is now a standard practice. What we do is if they come before 36 hours, we're all giving them the tocilizumab irrespective of the interleukin-6 levels. Any other questions?
So we do find that the interleukin-6 is usually not elevated in the first day or two of illness, but later on. Right?
Yeah.
So it's the MRI that gives you the diagnosis and then quickly to treat before the levels go up.
Okay. So there is a question. Yeah. Where does fires fall in the spectrum of fevers and seizures, and any role of interleukin-1 blockade for acute necrotizing encephalitis?
Okay, so the questions are on fires. Is it febrile infection related?
That was one question.
Yeah. Okay.
Where does it fall in the spectrum of fever and seizures?
Yeah.
And the second question is any role of interleukin-1 blockade for A&E?
Yes. Okay. So so fires is, we think of it as, yes, maybe part of the spectrum of the infection triggered encephalopathy syndromes, but not in the family of influenza or respiratory virus related ITES. And the ones I put out in the slide are mainly related to flu viruses and respiratory viruses. But in most children with fires, it could be any infection, right? And sometimes there is no pathogen as well. And often it's a very, very rapid descent into status epilepticus and seizures on focal seizures on both sides of the brain, right? So it may be similar in the way it begins, but maybe the biology is different. But there is some amount of immunity as well, and maybe innate immunity. And I think it's now shown that both interleukin-1, anakinra and tocilizumab, right, are both helpful in FIRES. But important to give it early, and you may need to repeat the doses of tocilizumab and continue with anakinra for a longer period.
Yeah, sure. Role of IVIG in acute necrotizing encephalitis.
Yeah, so I think there may be a role, but I don't know too much about this. Some of the Japanese work, I think, because they have more experience in this over the years, right, investigating and trying to treat ANE because it's fairly common to them. There's some work in the Japanese literature that imply that maybe IVIG is not as helpful. Essentially, we're trying to treat the innate immune system rather than the adaptive immune, right? So I think IVIG has more roles in the adaptive immune system. But that's it, right? I think many of us are given IVIG together in the sickest children, right? So I don't think it's something that you may not give. You can give it as well, but I think steroids.
Efficacy. Efficacy is not very clear whether it works or not. Yes, I agree with that. Dr. Dhiren Gupta has asked, does tocilizumab work for HSCS?
So for those children, the children decompensate and deteriorate into brain death very quickly within 48 hours, 24 or 48 hours. So I think the treatments may not be able to do much because it takes time to do something, right? It takes maybe a day or two to see a response to treatment. But by that time, the disease is so severe that they've just descended into brain death too quickly.
Yeah, true. Yeah, and the second question was, do you tailor the anakinra tocilizumab to interleukin levels for repeat dosages?
This is for FIRES.
I think Dr. Soludani. Yes, sir.
Okay. So for FIRES, I think what we understand is that the immune response, at least there's some work that I know of, some of my colleagues are doing, measuring the cytokines in the CSF in patients with FIRES longitudinally. So the immune response dissipates very quickly. I think within a week you would see that a week or two that you would not be able to detect any more cytokines, but the patient is still sick with refractory status. And we do find that sometimes patients take some time to come around. So I think the repeat treatments of tocilizumab and how long you continue the anakinra should really be clinical, not by any measurement of cytokines.
Yeah, sure. Thank you.
So thank you, Dr. Terence and Dr. Lokesh, for that wonderful session. So Dr. Terence, we would like to request you to take up some of the questions in the Q&A box. If you could just type your answers there if you have time, that would be very helpful. Thank you.
Yeah,
I would now like to request Dr. Dhiren to kindly introduce our next speaker, Dr. Rakashdeep. Over to you, sir.
I would like to thank Rakshay for inviting me, for giving me opportunity to attend this wonderful concept. And I could see there are 3 Dhiren Gupta on the screen. So I will request the people, they can change their. And now I was listening to the last talk, though intermittently, but what I could say over the years that most of the clinicians do get confused that they have got 4 or 5 armamentarium like steroids, IVIG for systemic inflammation, and some filtration processes like you can have cytosorb and other filtration, CRRT you can use, plasmapheresis you can use. So many biologics. So people are getting confused a little bit over the years that what to be used in this type of situation. Like liver also can lead to systemic inflammation. Systemic inflammation can happen secondary to bacterial infections also, which is common in India. But we have seen during COVID also, despite of very high procalcitonin, that it was just a sterile inflammation and steroids were mainly helpful. but people didn't believe and started with IVIG. Then everybody thought that steroid is the main. So these type of confusions do happening. So I'm hopeful that the next speaker, that is Dr. Akash, and he should be able to solve many of the situations, especially when we talk about fulminant hepatic failure. And when I start talking about Akash, means the whole conference will end just by his introduction. So briefly, what I can say, he's a wonderful friend, wonderful, teacher, and very lovely clinician. And the beautiful part of Akash is he shares experience, and also this way our units have grown, and we're able to use advances in our ICUs. So what we know about Akash is he's in King's College for so many years, and he's now director of pediatric ICU at King's College Hospital, London. He's a chair of scientific affairs of European Society of Pediatric and Neonatal Intensive Care, ESPNIC, chair of liver failure working group of ESPNIC, and chair of scientific and education committee of UK. As I told you, that means he's got so long introduction and so impressive introduction. So we come to the topic, that is systemic inflammation and fulminant hepatic failure. Akash, all is yours.
Thank you, Dhiren. Very kind introduction. Thank you, Rakshay and the Rainbow Group, for inviting me. And I think I'm very thankful for getting a chance to speak on something which normally used to be a minuscule part of my talk on acute liver failure. And I would just say, systemic inflammation is implicated in acute liver failure. So today I've got a chance to discuss with you all what is systemic inflammation in acute liver failure and what impact does it have on the clinical course and on the treatment which is available for acute liver failure. So to begin with, I've got no conflicts of interest. So to give perspective to this talk, I thought we'll just start off by talking about the causes of mortality in pediatric acute liver failure. And very importantly, talk why is liver considered as an immune organ? And that will pave way for me to talk on the role of systemic inflammation in pediatric acute liver failure, causing multi-organ failure, including hepatic encephalopathy. We'll talk about how closely is infection and inflammation correlated and how they're interdependent on each other, which again leads to the progression of multi-organ failure, hepatic encephalopathy. We'll touch upon the role of extracorporeal support as an anti-inflammatory and immunomodulatory therapy, as Dhiren was just mentioning, plasma exchange cytosorbents. And then in the end, we talk about what is the timing of extracorporeal therapy in these patients depending upon the inflammatory state. We'll talk about the novel extracorporeal therapies which are specifically targeting the inflammatory molecules. And we'll talk about the cellular regeneration in the form of mesenchymal stromal cells because they have got anti-inflammatory and immunomodulatory properties as well. So what I discussed with Rakshay was that let's not make it a basic science talk. I'll try and make it a clinical talk based on a systemic inflammation on the pathophysiology, the consequences on the clinical course, and the therapeutics available. So let's start off by talking why patients with fulminant hepatic failure are dying. Historically, it used to be cerebral edema with raised intracranial hypertension and sepsis with multi-organ failure. Now, there are loads of molecules which are implicated, which are both water-soluble, they are protein-bound, but one molecule which was initially implicated as the treatment point was ammonia. As a bedside clinician, we can measure it. As a bedside clinician, we can act on it. And therefore, if you look at this human evidence, you see that higher the levels of ammonia at presentation, higher is the chance of hepatic encephalopathy and higher is the mortality. It's not only hyperammonemia at presentation, it's a persistent hyperammonemia at 48 hours. You can see here with the Kaplan-Meier curve, if you've got an ammonia less than 200, your chance of survival is higher as compared to children whose ammonias are more than 200. Therefore, high ammonia levels at admission and persistently high ammonia levels are bad. And this effect of hyperammonemic cerebral edema gets potentiated by hyponatremia because that will act by the same mechanism as well. Hyponatremia, hyperammonemia combination is bad. But what has completely revolutionized our thinking or about the pathophysiology of acute liver failure is the concept of systemic inflammation. People say that immune dysregulation is now recognized to be absolutely central in the pathogenesis of acute liver failure. It's an innate immune-driven disorder. You've got monocytes, you've got macrophages, which are key determinants of the initiation, the propagation, and the resolution phase of acute liver failure. And you can see here, the first step is when your hepatocyte dies. Loads of DAMPs get released, macrophages get activated, and they all go on to have the phenotypic markers of your monocytes and your neutrophils getting activated, converting them into a pro-inflammatory monocyte, the pro-inflammatory neutrophils, and they then produce lots of pro-inflammatory cytokines. So in summary, what happens is there's a hepatocyte death. It triggers the release of DAMPs that activates your innate immune cells in the liver and the circulation, especially your macrophages, and it leads to tissue inflammation and systemic inflammatory response syndrome. Now, this is a slide which tells us a lot. This tells us that liver is a highly immunogenic organ. It's a solid organ. It's one of the largest organs in the body, which has got a unique anatomical and immunological site, because you're bringing in antigen-rich blood from the gastrointestinal tract through the portal vein, and that is then compressed through a network of sinusoids and then gets scanned by the antigen-presenting cells and lymphocytes. You can see this is the portal tract here. You've got a bile duct, the hepatic artery, the portal vein, and these hepatic artery and the portal vein, the dual blood supply goes and gets compressed within the sinusoids, and you can see this is the resident phagocyte of the liver called the Kupffer cells. You've got a natural killer cell, you've got T lymphocytes, you've got B lymphocytes, and you can see that the difference or a distance between the two endothelial sinusoidal cells is very, very small, which means that these cells are in very close contact with the sinusoidal cells, and hence the lymphocyte gets activated. So we need to remember here is you've got an organ which has got lymphocytes, which are slightly different from your circulating lymphocytes, and they are called the tissue resident lymphocytes, but very specific to the liver. So liver in itself is a very highly immunogenic organ. If you look at this slide, this tells us the various cells. Look at the neutrophils first. If you've got a patient who's got acute liver failure, you will get a significant reduction in neutrophil surface expression of CD16, which means that the neutrophilic phagocytic activity as compared to healthy controls will be much lower. Therefore, that can lead to more infections and predict death without transplantation. And similarly, if you've got neutrophils in patients who've got paracetamol-induced acute liver failure, you get toll-like receptor hyperexpression, which means that this patient's severity of hepatic encephalopathy and SIRS will be more. And if you look at your monocytes and macrophages, either singularly or together, you will see that the production of chemokines will be affected. And lastly, we know that the complement system also gets produced in the liver. There will be defective opsonization, and therefore, again, that can lead to immune problems in a patient with fulminant hepatic failure. So liver, an immune organ, different cells all get defective, leading to immune paresis, or you can say initially a pro-inflammatory state followed by the CARs. Now, this is a slide which shows us the three different compartments. You can see here, this is your liver, this is your circulation, and this is your extrahepatic organs. And what I'm trying to say here is that the hepatic macrophages, they've got diverse role. The same macrophage will work as a pro-inflammatory cell, and the same macrophage after a few days, or depending on the tissue microenvironment, will serve as a pro-resolution. It is very, very plastic. You see here, you get a DAMP signal here, you get the proliferation, and this is your activated M1 macrophage. And what that does, it produces your pro-inflammatory mediators, TNF-alpha, IL-1, chemokines. Then you get this defect in the vascular endothelium and the microcirculatory disturbance, and all these cytokines are spilling over to your extrahepatic organs, causing microglial activation, hepatic encephalopathy. You get bacterial translocations. But if you see it in the resolution phase, it's the same macrophage which started your pro-inflammatory cytokine storm, it becomes your pro-resolution, which means that your anti-inflammatory mediators, IL-10 and SLP1, they will be produced more. So which means that you can either switch off your pro-inflammatory response, or if this anti-inflammatory or a compensatory anti-inflammatory response persists, you can go into immune paresis, leading to sepsis and the further complications. And this is exactly what I was talking about. This is your pro-inflammatory macrophage. This is your pro-resolution macrophage. And it is this plasticity of this macrophages, which is going from pro-inflammatory to pro-regenerative, depending upon the microenvironmental mediators, which is very classic in a patient with fulminant hepatic failure. As I said, we talk about sepsis and inflammation. Very important role in the inflammatory process. You've got a compensating anti-inflammatory response. You've got monocyte dysfunction and inactivation of interleukin 10. You've got a decreased serum complement because that's again produced in the liver. So as I mentioned earlier, name the cell which is not defective, and you will get, that is the problem with the patients with acute liver failure. Now here is the one which I was just talking about. You get initially a pro-inflammatory response, and the anti-inflammatory response is not there. As time passes by, if the pro-inflammatory response is very profound, you get mortality here. So excess pro-inflammatory response, early mortality, excess anti-inflammatory response later on, leading to persistent CARs. It leads to recurrent sepsis and again leads to multi-organ dysfunction syndrome. And therefore, there is a distinct correlation between your SIRS, your CARs, and mortality. This was Jules Wenden's team from King's who looked at the systemic inflammatory response syndrome in acute liver failure. And they looked at 880 patients. Some of them had confirmed infection, some of them didn't have confirmed infection. And what they found was that the number of components of SIRS correlated to the progression of hepatic encephalopathy. It did not matter whether you were infected or not, but if you look at here, the maximum number of concurrent SIRS components during admission, higher the number of SIRS at admission, higher are the patients who die. So what they concluded was patients who have got a SIRS on admission was likely to subsequently develop worsening encephalopathy or elevation of intracranial pressure, suggesting that SIRS may precipitate progressive encephalopathy. Infection, a very important cause of inflammation, but it's the magnitude of the patient's response to inflammation that appears to determine the prognosis. And what they feel is the SIRS is the final common pathway to encephalopathy, and that infection is a major cause of SIRS as well. So in acute liver failure, it doesn't matter whether SIRS is precipitated or not precipitated by infection, it appears to be implicated in the progression of hepatic encephalopathy. So a very close correlation between infection and inflammation. And as you can see, infection leading to inflammation, more inflamed you are, more there's a propensity to get infected. So very difficult to tease out what is the cause and effect in this relationship between hepatic encephalopathy and infection. And then is your liver-brain axis correlation. You see here that intracranial hypertension is strongly linked to the SIRS response. Acute liver failure results in hyperammonemia and systemic inflammation, increased levels of ammonia in the brain, lactate accumulation in the brain. They stimulate the microglia. You have increased levels of pro-inflammatory cytokines and neuroinflammation, leading to encephalopathy. And this absolutely highlights the profound effect of inflamed liver on extrahepatic organ function. You've got inflamed organ, and that predisposes to loads of inflammatory mediators being struck out of the liver into the systemic circulation. So hepatic encephalopathy, yes, I agree that hyperammonemia is a central factor, but it is not the single pathophysiologic point. You also have inflammation, including the cytokine generation within the brain, in addition to cytokines which have crossed the blood-brain barrier from circulation. Now, this is the paper by Phil Larson, and where they looked at the points at admission and at the onset of hepatic encephalopathy, and they found that if you have got hepatic encephalopathy plus SIRS, the mortality was 63%, and if you didn't have SIRS, your mortality was 23%. And what they found was that the cutoff of lactate of 4, more components of systemic inflammatory response, and higher SOFA scores in patients who progressed to hepatic encephalopathy and they died. So spillover of inflammatory mediators from the liver failure leading to a chaos in systemic inflammation leading to multi-organ failure is characteristic, or I would say central to the pathophysiology, the pathogenesis of a patient who has got acute liver failure. Now, this is the natural course of a patient with acute liver failure. Normal liver function, rapid decline, Some patients would die awaiting a liver transplantation. Some patients get liver transplantation, but there's also a group of patients who might recover spontaneously. What we need to do is to enter at this stage where the liver failure is failing fulminantly, and you need to introduce your multimodal, multi-organ support, and that includes your extracorporeal support, which works not only to remove the toxins, but to also modulate your inflammation and work in the immunomodulatory therapy. And their role, as I said, is control of inflammation, to remove the cytokines and modulate your immune dysfunction so that you have got a conducive environment for liver regeneration. Or in case you're not getting a liver regeneration, they might work as a bridge to liver transplantation. So this is the extracorporeal support. Most commonly CRRT is used, but of course we'll be talking about a modality which works as an immunomodulator, anti-inflammatory modality, the plasma exchange. It performs both the excretory and the synthetic functions of the liver. And going back to the same cartoon I showed you, where there was a monocyte activation, the pro-inflammatory monocytes, the pro-inflammatory neutrophils, what high volume plasma exchange does, it dampens the pro-inflammatory response by removing the damps. There's a definite decrease in the concentration of TNF-alpha, IL-6, and the phenotypic markers of monocyte activation, which are activated the monocytes here. You can see they're all getting depressed, and the neutrophil activation is also mitigated, which means that the whole SIRS, the SOFA, the Cliff SOFA scores, which are associated with acute liver failure, they become dampened. And this was the study by Finn Larson and Jules Vanden from King's, looking at standard medical therapy versus high volume plasma exchange. And they looked at liver transplantation-free survival. And you can see here that the maximum effect of high volume plasma exchange was seen in those patients who were not listed for transplantation because they had a contraindication, or they had to be delisted whilst on the list because they developed contraindications. You can see in both the cases, there's no transplantation, but there's a massive difference in survival, transplant-free survival in those patients who got high volume plasma exchange. And very interestingly, as a proof of concept, these authors looked at TNF-alpha, IL-6, and there's a definite decrease in the concentration of these markers, and earlier initiation, less than 48 hours versus more than 48 hours, earlier initiation seems to remove more inflammatory, pro-inflammatory cytokines than if started early. And these authors then went on to conclude that plasma exchange, or rather high volume plasma exchange, works by reducing your pro-inflammatory response, by immune modulation, by dampening your pro-inflammatory response and attenuating the innate immune system, by attenuating your macrophages, attenuating your monocytes. Then, of course, there was a debate upon, do we really need to use the high volume plasma exchange? Using 8 to 10 liters in adults is a high volume, lots of cost, lots of problems for the blood bank. Can we get away with standard volume plasma exchange? And this was a study which showed that even with standard volume plasma exchange, you are able to bring down your pro-inflammatory, you're able to bring down your anti-inflammatory, and you're able to modulate the monocyte phagocytic function. Therefore, standard volume plasma exchange should suffice. At King's, we use 1.5 to maximum of twice the circulating plasma exchange. Coming to cytosorbents, this works on the principle of beads rather than convection or diffusion. It absorbs your inflammatory mediators like your cytokines, like your trigger substances, the DAMPs and PAMPs, and has been shown to have a role in acute liver failure. And you can use your standard CRRT machine, both in the pre-filter and your post-filter phase. And what it does, it absorbs these cytokines. But remember that the priming volume of this cartridge is about 200 mils, which means that you will end up blood priming most of your patients. And then you can talk about hybrid therapies where you use your CRRT, you use your high cutoff membranes, use your cytosorb, and you can see nicely when you use the hybrid therapy, because of impact on your inflammation, your epinephrine and your norepinephrine doses are coming down. Then you have got a membrane, the auxiliary membrane, which has got 3 kinds of layers. You've got a first layer which absorbs your cytokines, which means you're able to dampen your response. Your second layer absorbs your endotoxins, and the third layer has got heparin coated, which means it will reduce your thrombogenicity. And by using this, you're using 4 properties in one device: renal support, cytokine removal, endotoxin removal, and your local anticoagulant effect. But what I see as the future is this. You look at any device, extracorporeal device, CRRT, plasma exchange, cytosorbent, what it does, it absorbs your cytokines. But those organisms, those cells which are producing these cytokines are still alive. And what the selective cytophoretic device does is actually it inactivates your activated neutrophils, your activated macrophage, you dampen your cytokine storm and actually prevent the organ damage. And this is what happens. You've got a hemofilter, which is normal, and then you attach your selective cytophoretic device and it goes back to the patient with a low flow. But the problem with this device is that it requires a very low ionized calcium because neutrophils require higher calcium for their activation. So it requires low calcium, which means we need to use a higher dose of citrate. And as we know in liver failure, the metabolic capacity is decreased. Therefore, we might not be able to use citrate, and that's a work in progress for this team. And the mechanism of action is selective binding of neutrophils, selective binding of monocytes. And as I said, neutrophil activation does require higher ionized calcium. So most activated neutrophils and pro-inflammatory monocytes are able to bind to these membranes due to the low ionized calcium. And I think this is a most appropriate therapy at this moment, as long as we can sort out the ionized calcium in these patients. Now, to make things more complicated, you can see here the TNF-alpha and IL-6, which started the inflammation. But if you look at the cell cycle here, the same cytokines, the same TNF-alpha, the same IL-6 are also starting the priming process of the cell cycle, which means that if you remove these cytokines at the inflammatory phase, it will dampen the systemic inflammation. But unfortunately, at the regenerative phase, it might inhibit your regeneration, and we do not have a specific biomarker to tell us that. Again, showing you here that if you're removing your macrophages at this stage, you're gonna dampen your pro-inflammation. But if you remove at this stage, unfortunately, you will be removing your regenerative molecules as well. So what is the future of extracorporeal or immunomodulatory or anti-inflammatory therapies, you want to call it, to biomarkers which can define the stage of hepatic injury in acute liver failure? If you can predict the cell death, which the biomarkers of hepatocyte death, which peak early and decline early, or if you can able to predict the late markers of regeneration and immunosuppression, which characterize the regenerative phase, for example, alpha-fetoprotein, phosphate, or mononuclear deactivation, you should be able to say, look, I am in the regenerative phase, I need to go slow, or I'm in the pro-inflammatory state, I really need to hit them hard. So what is the future? The future is to integrate your inflammatory biomarkers with the biochemical and functional markers of liver function, and to have those biomarkers which can separate out your infection from inflammation, and your immunomodulatory therapies to promote liver regeneration and decrease the nosocomial sepsis should be in the forefront. This is a cellular regeneration. We know from literature that auxiliary liver transplantation works. So singular cell units, the hepatocytes, have been used through the portal vein to promote the cellular regeneration of the liver till the liver transplant becomes available. But if you have got mesenchymal stromal cells, which you can get from umbilical cord, from the bone marrow, and if you actually mix them with hepatocytes, you can get increased viability, increased attachment, because the mesenchymal cells work as anti-inflammatory, work as immunomodulatory, they help in tissue regeneration, and they decrease the oxidative stress. And this is what we are starting at King's very, very soon. We've got hepatocytes co-encapsulated with mesenchymal stromal cells in alginated microbeads for the treatment of acute liver failure in pediatric patients. It's called the HELP trial, and it will start imminently. So this is just to summarize exactly what I have said. We said hepatocyte death, we talked about dams, we talked about monocytes and neutrophils going into inflammatory process, and macrophages getting activated. You get hepatic and systemic inflammation, which leads initially to a cytokine storm, and thereafter it can lead to sepsis and infection if your compensatory anti-response syndrome becomes more. Therefore, understanding what phase we are is very important. So understanding the pathophysiology, including the individual components involved in immune dysregulation and the role of infection, is vital to the development of novel Treatments and monocyte and macrophage numbers and function may be the key and should be a priority focus in human research. So this is a very clinical paper we published last year in intensive care medicine, looking at the non-transplant measures in pediatric acute liver failure, what is new. And if you look at it, we very specifically talk about immunomodulatory therapies in the form of cytokine removal, innate cell deactivation therapies. We talked about plasma exchange, and we talked about immunotherapy if macrophage activation syndrome or HLH is present. So this is my last slide. We've seen there's been a huge paradigm shift from most requiring transplantation to most recovering with spontaneous native recovery with medical therapy alone. What has made a difference is the use of high volume CRRT and the use of total plasma exchange as immunomodulatory agents. We control sepsis early, we use antibiotics, antifungals, therefore the interdependence of inflammation and infection is taken care of. And of course, we talked about mesenchymal cells, which again work as anti-inflammatory as a bridge to liver transplantation. And in the end, this is an invitation to all of you. We're having a CRRT International Congress in London, so please join us in July. Thank you.
Thank you, Dr. Akash, for really wonderful and wonderful talk. And you actually summarized
Dhiren, I can't hear you.
Okay, now it's fine. It's better. Yeah. So what we have learned from you for so many years that we have got two modalities. One is the CRRT and second is the plasma filtration, that is plasmapheresis. So if your ammonia alone is very high, rest of things, bilirubin is not very high, so then your CRRT will do, but otherwise plasmapheresis has got edge in liver failure, right? Now, my question is to the people, you know, because in India, in many centers, we don't have all these therapies. And even a person who want to refer this patient for transplant centers. So as per the previous talk and the present talk, there's an inflammation, right? And there are going to be markers for inflammation. Are there markers like CRP? See, we have ruled out infection. We know that it's very difficult to rule out infection in any given case. But if you have ruled out bacterial infection or fungal infection in a given case, it's like a clean case. Can we have an idea about the inflammation going on based on CRP1 or any other marker? Second, we all know that there's a role of CRRT and filtration and all these sophisticated things. We use them very, easily and comfortably in our unit. But I'm talking about pan-India centers. Like, can we use drugs like steroid 1 dose before referring, IVIG 1 dose before referring? Drugs like tocilizumab, as you told us that IL-6 and anti-TNF has got a role. So tocilizumab and infliximab drugs can be used in liver failure before it's like bridging a gap before we start CRRT and other therapies. I'm talking about a pediatrician who is managing and who is taking time to transfer this patient to the liver transplant center or the center where all these modalities are there. So this is my major question I want to ask.
Then would you mind just repeating your first question? I got your second and third.
My first question is, can the monitoring parameters like CRP, IL-6 can have an edge, give us an edge that what type of anti-inflammatory mediator we can, anti-inflammatory drug we can use?
So therein, I think liver becomes a very complex organ because, as you know, CRP is mainly produced by the hepatocytes.
Yes, yes.
So once your liver fails and the hepatocytes are necrosing, you cannot depend on CRP alone as your marker, right? So that, for me, that is the biggest problem, that your CRP becomes redundant. Of course, if it is high, that can tell you two things. A, you've got enough hepatocytes to produce CRP, but I would go by ProCal. What we at King's do is, for example, you're right, we get a call from a district general hospital, a local hospital, which doesn't have a PICU, which doesn't have, our first advice always is to do the standard etiology specific treatments, because if you tell me what makes a difference to the management of these children is finding the etiology if you can, because as you know, 40 to 50% of these patients are left with no etiology despite doing the most funky tests. If you don't start etiology-specific treatment, you come into the category of indeterminate, and the incidence of hepatic encephalopathy is higher in those kids. To answer your question, CRP cannot be dependent on that. We ask them to start prophylactic antibiotics and prophylactic antifungal in most of our patients with acute liver failure. They come to us on that. Regarding the question of steroids, that's fascinating, because I'm sure you all heard about the outbreak of hepatitis which took place last year, and people were talking about it left, right, and center. People were saying, is it associated with adenovirus? Is it associated with COVID-19? And centers who actually used steroids preemptively, there was always a hesitation of sending a patient on steroid, but people could be an immune phenomenon secondary to COVID. And those patients, I can say a few of them did avoid transplantation. So what our indication at King's for steroids is a suspected immune-mediated phenomena, or if you're dealing with HLH, these are the two main indications of using steroids in patients with acute liver failure. Regarding CRRT and plasma exchange, again, centers in India, I know that you guys have got SLED quite a lot and you use it. I would say something is better than, I would in an ideal world want to use a continuous modality, because ammonia can have a rebound effect as well, as you know. But if you don't have it, we can use prolonged intermittent renal replacement therapy, which is between SLED and CRRT.
Yeah, and regarding tocilizumab and infliximab, because the pathophysiology which you showed us, they mentioned that the TNF and IL-6. So I'm talking about, see, most of the centers who have these slide machines do have CRRT and the plasmapheresis machine. I'm talking about a doctor. Before referral, can he use one dose? Because many times we have seen that inflammation has actually killed. It was not an infection. Especially if brain is affected, then many times you can't transplant a liver. So the disease the patient becomes futile, outcome becomes futile. So just a rescue therapy.
So then if you look at, I'm purely going by evidence, and evidence is only in the preclinical studies. They have used anakinra, for example, but it's not a routine use. If you ask me what anti-immune modulatory, anti-inflammation drugs I have used, we hardly use anything, not because we have got access to CRRT or plasma exchange. It is just that we don't have enough evidence to say what immune, the cells are going to get affected by what drugs. So I would not recommend it as a routine. Yes, if it is discussed with immunology and with hepatology and they feel there is something they can target, 100%. But as an intensivist, I am not in a position to say it should be used routinely.
Yeah, because during COVID, we were scared of using tocilizumab because it leads to immunoparalysis. So we have seen that patient dying because of fungal infection. I'm talking about adult. In pediatric, we didn't use much. Steroid were sufficient. So I was just, going through your presentation. So I thought that these may be beneficial. Thank you very much. And again, it was a wonderful talk. It was well-researched talk.
Thank you. Thank you very much. And thank you, Rakshay. Thank you, Dr. Udari. Nice seeing you all. Bye.
So thank you, Dr. Akash and Dr. Dhiren, for that session. I now request Dr. Sonu Udani, if possible, to introduce our next speaker, Dr. Pratik Sinha.